Welcome to today's UCLA webinar. I'm Dr. Tara McCannel. I'm the Director of Ophthalmic Oncology in the Department of Ophthalmology at the Stein Eye and Doheny Eye Institutes. Today, I will be sharing with you ocular melanoma, what you need to know. As an overview, the first issue that I'll discuss is getting a diagnosis. The next issue will be deciding on your treatment. Next, I'll be talking about ocular melanoma treatment at UCLA. And finally, I would like to talk about what you can do to improve your health after your treatment. Getting your diagnosis. You've just seen an eye care provider, and there is concern that you may have a growth, a tumor, or a possible ocular melanoma of the eye. How is this diagnosed? Perhaps you had a retinal screening photograph, which we are finding picks up small pigmented spots very early compared to the past. Or perhaps you had new symptoms that took you to the eye doctor, such as flickering, shimmering lights, or you noticed some new floaters, and an ocular tumor was diagnosed. Or you knew you had a freckle, and this has been undergoing continual surveillance, and your doctor was worried because it looked like the lesion had grown. Let's talk a bit about ocular melanoma for a review. The word ocular, uveal, choroidal melanoma all refer to the same thing. These are intraocular pigmented cancers of the eye. It is the most common primary intraocular tumor of adults, and although serious, it is rare, with 5 to 6 cases per million per year. So that's about 2,000 cases in the United States a year. Even though we've studied the features of ocular melanoma in detail, there are no identifiable and specific risk factors that we know of. There are more cases in people with blue or green eyes, and the majority of people, but not everybody, has melanoma may have less pigmentation of their skin. Let's review some of the normal eye. In the front of the eye, you have the anterior segment. This is the lens, which forms a cataract, and this is the cornea, the clear coat of the surface of the eye. Everything to the right of this picture is the posterior segment, where the vitreous humor is, which fills the back part of the eye, and the retina, which lines the eye, the inner aspect of the eye wall. A melanoma, which forms in the eye, often forms underneath the retina, in sort of growing from the wall of the eye. Here is an example of an eye that was removed or enucleated, and you can see the tumor, which is mushroom-shaped on the inside of the eye. You can also see that there's retinal detachment associated with the melanoma, and this is something that we commonly see. Here are a series of photographs of different types of ocular melanoma, including at the bottom here, a melanoma of the iris. And you can see that they all look very different. So how is the diagnosis of ocular melanoma made? Because the tumors have such a variability of appearance, sometimes the diagnosis is challenging. There are many benign conditions that can look the same as an ocular melanoma. What is probably most important is clinical experience. Has your doctor seen a lot of melanoma or a lot of lesions or freckles? Are they comfortable with the diagnosis? You may have read about specific features or a checkbox of items that a melanoma must have in order for the diagnosis. But I can tell you, in my experience and others, the clinical features that we think are typical in melanoma may not be present. However, we do see many melanomas with subretinal fluid and with orange pigment and in various locations of the eye. And I'd like to point out that particularly when the tumors are small, they can mimic a variety of conditions. What about pictures and imaging, tests that can be done to help with the diagnosis? There are a lot of tests involved in evaluating a person who might have a melanoma. Photographs can be helpful to document the lesion and the features. Angiography is the dye test where fluorescein is injected into the vein and passes through all the vessels of the body, and the vessels of the retina and vessels associated with the possible tumor can be studied. There are OCT scans, which stands for optical coherence tomography, which show us cross-sections of parts of the retina and can show cross-sections through the tumor. This helps show the interface between the tumor and the retina. And then there's ultrasonography, and this uses sound wave patterns through the tumor itself, which can identify features and can also provide accurate measurements. But I'd like to point out that in ocular melanoma, there is no single test, no single photograph or study that is done that tells us the diagnosis. So what is the best way to diagnose an ocular melanoma? And I've been asked this question a lot. And I think the two most important pieces of information when we're figuring this out is a patient's history. If there are symptoms, what are those symptoms like? How often have they occurred? Do they vary with activity? Have they changed or improved with time? Many times, by taking a careful history, you can figure out if the lesion is benign or malignant. Secondly, the clinical examination. This is seeing the patient, seeing the eye in real life. Photographs are helpful for sure, but seeing the tumor and its features in three-dimensional reality in the context of the patient is invaluable. And this is why sometimes making the correct diagnosis is challenging. If you are uncomfortable with the decision or you're not sure, please seek a second opinion. It is normal today and customary, particularly with all the information that is available online, to get different opinions and seek different experience. In fact, ask your doctor if they can help you get a second opinion if you'd like more information. What are the effects of ocular melanoma on patients? There are really two major effects. One is on vision and one is on mortality. In melanoma, there can be visual loss in the eye with the tumor. The tumor itself can disrupt the layers of the retina and alter and change the vision. Secondly, the side effects of treatment can also impair the vision. Of most concern is the risk of metastatic death. Like any type of cancer, ocular melanoma also has the risk of spreading to other parts of the body. If this cancer were to spread, it tends to go to the liver. However, it is rare to have spread of the cancer at the time the tumor in the eye is diagnosed. What are the ways that we can treat ocular melanoma? In the past, before we had our modern therapies, there was removal of the eye, called enucleation. Fortunately today, this is infrequent, partly because we have better treatments and also because we are detecting melanoma of the eye sooner than we have been in the past. If the tumor is very large and the vision to begin with is very poor, your doctor may recommend enucleation. The most common way that we treat the eye when we are saving the eye is using radiation therapy. We can do this by putting a plaque on the eye, and this is also a term called brachytherapy because the plaque contains seeds of radiation. Or radiation therapy can be delivered other ways, and we call this external radiation, and this can be delivered by proton therapy, stereotactic, cyber knife, gamma knife. There are other ways that radiation can be administered. Here's an example of an eye that has been removed or enucleated. And to the right, this is a photograph taken during eye plaque surgery where we are saving the eye. And the plaque, you can see here in the picture, is one of our gold plaques that we use at UCLA. Now, what about just taking the eye out? Why would we save the eye when we want to just get rid of the cancer? Well, a lot of studies have shown that there is no survival advantage by removing the eye. So whenever we can, we recommend treating the tumor and saving the eye because that will give us the best chance for vision in the eye after treatment. What about other forms of treatment? And again, there's information about different forms of therapy. Laser therapy in all forms has been largely abandoned due to the high rate of treatment failure and local recurrence. Sometimes a patient will come to me and they'll ask about, can we do laser to treat the tumor? The studies have shown that tumor recurrence is very high if we use laser therapies. There has also been studies performed using surgical resection. That's cutting out the tumor. And a lot of people ask, can't you find a way that you can just cut the tumor out of my eye? Well, in North America, surgical resection is rarely performed because there is a higher rate of tumor recurrence, so tumor still left in the eye, and there is significant morbidity to patients who undergo this treatment as hypotensive or very low blood pressure must be maintained throughout the time of surgery. So we generally don't recommend this because of the high risk to patients, high risk to people's general health as they undergo the treatment. Let's talk about melanoma treatment here at UCLA. As our mainstay of treatment, we use brachytherapy, which is plaque treatment, to kill the tumor in the eye. In addition to our center, probably nationwide, brachytherapy is the most common way that melanomas are treated. We perform a radiation treatment plan in consultation with our radiation physicists and radiation oncologists here in the Department of Radiation Oncology, and clinical examination, ultrasonography, and a treatment plan is used by our team to come up with the best treatment for each individual tumor. At UCLA, each plaque is custom built based on the dimensions required for adequate tumor treatment. Because we have customized and individualized treatment therapy plans, we have the flexibility to treat all sorts of melanomas that would normally be considered untreatable. For example, tumors that are located at the optic nerve or macula are routinely treated here at UCLA. When a person comes for surgery, it's outpatient surgery, meaning we perform our surgery in a surgery center and you don't stay overnight in the hospital. We give something called monitored anesthetic care, which is intravenous sedation, so that you are in a twilight state throughout, and the eye is numb, so you don't feel very much during the procedure. After the surgery, there will be a patch on the eye, and we place a wristband to indicate that there is a source of radiation on the body. Here's a photograph taken during plaque brachytherapy surgery. You can see that it is done in entirely sterile conditions in the operating room. During the surgery, we perform ultrasonography in every patient. The ultrasonographer who you meet at your first appointment comes to every surgery so that we can accurately determine the dimensions of the tumor throughout. This way, we maximize the accuracy of your treatment. We have shown in reviews of the literature that when ultrasonography is performed, this significantly reduces the rate of treatment failure. And at UCLA, we do use ultrasonography to improve our outcomes. What about tumor biopsy? This is something that many people may have read about. UCLA was the first center in North America to offer prognostic biopsy for melanoma patients. Today, it is considered the standard of care at all major ocular oncology centers around the world. If your doctor has not mentioned biopsy, I would recommend that you have a discussion about this. Biopsy is important because the tumor tissue itself contains markers that can tell you how likely the melanoma may spread in the future. We can find tumors that are at low risk for spreading and identify those at high risk for spreading. And we use all features of the tumor, not just the molecular markers, but the size and details of the patient themselves to help us get a better idea about their risk of metastasis. But what about the safety of biopsy? If you go to the internet, there is a lot of information that may make you worried about having a biopsy. Ourselves and many other centers now have published on the safety of this procedure in experienced hands. The tumor biopsy does not increase the risk of spreading the cancer in the body. And it does give valuable information that patients want to know so that they can plan their life. Let's talk a bit about vitrectomy surgery. Vitrectomy is a special name for surgery that is performed to remove the vitreous humor in the back of the eye. We are all born with vitreous. In development, this is the substance that the eye forms around. Later in life, the vitreous is what contributes to floaters and can sometimes cause standard retinal detachments that can happen to people. In retinal surgery, the vitreous is often removed because it may contribute to disease. And once the vitreous is removed, the aqueous humor, which is made in the front of the eye, fills the space in the back of the eye. When would we consider vitrectomy with plaque surgery to treat a melanoma? When a person has a very small tumor, usually less than 2 millimeters in thickness, we can use very small gauge vitrectomy instruments to obtain tissue so that we can get genetic testing for molecular prognostication. And there are no additional restrictions or special positioning required after the surgery. In people who have larger tumors, at UCLA, we use vitrectomy to place silicone oil inside the eye. After the plaque has been accurately positioned with ultrasound, the vitreous humor may be removed and replaced with silicone oil. And the reason we use a silicone oil is because it shields, it prevents the radiation from getting to the healthy tissue in the eye. We have demonstrated that it reduces radiation retinopathy and improves vision in patients. Also, there may be a retinal detachment in the eye with the melanoma. Silicone oil can treat the detachment. In these cases, we might ask a patient to sleep in the face down or side positions for the first night of surgery, but not afterwards. It's a short engagement. So how does this work? When we treat a melanoma, we put a plaque, which is this gold disc, on the sclera outside of the eye, just behind the tumor. To treat the tumor, some of the rays of radiation may affect the healthy non-tumor tissue in the eye. If we replaced the vitreous humor by doing a vitrectomy with a substance that could block or shield the penetration of the radiation, then we limit those extra radiation rays from harming healthy tissue in the eye. So we have published on this in the field, and this is a proven method for reducing radiation retinopathy in patients undergoing treatment for ocular melanoma. This was our first study. This is the second study in patients, and most recently, our study in large tumors shows significant benefit by 2 years after treatment. Here is a graph that shows good vision and poor vision. The blue bars are when we use plaque alone. The red bars when we use plaque with vitrectomy and silicone oil. You can see that there are more patients with good vision and fewer patients with poor vision when we use vitrectomy and silicone oil. Why is silicone oil important? The biggest side effect that can happen to an eye that undergoes therapy for ocular melanoma is blindness from radiation retinopathy. There is no effective long-term treatment, although there are drugs that we can inject into the eye that may temporarily keep the vision better than without. Although the drugs can be placed in the eye, they are not effective in the long run. Recently, I heard 2 prospective, randomized, multi-center trials that demonstrated that there is a failure of long-term benefit of injecting these drugs in the eye. If there is no treatment for radiation retinopathy, prevention is what we need, and silicone oil is the only demonstrative preventive strategy that may improve the vision and reduce radiation retinopathy over time. Now that the tumor's been treated, let's talk about what we do after. What can you do to improve the health of your eye and your body after the cancer has been treated? We recommend that ongoing systemic screening with imaging studies be performed by a hematologist-oncologist to watch for metastatic disease. There is controversy in this area because we don't have a definitive cure if metastatic disease were to occur. But there are so many new treatments and new drugs that are coming online in the field of oncology that early detection of metastatic disease is important if we are to have options open for evaluation. I also recommend that people have continued follow-up with either their ocular oncologist or a retina specialist to detect treatable side effects. Other side effects that can happen in an eye with melanoma or in the healthy fellow eye are cataract, glaucoma, retinal detachment, retinopathy, and many of these things are treatable. And if we don't look for things that are easy to treat, we may easily miss them, particularly when the seriousness of the melanoma often overtakes everything going on in that eye. What can we do to improve one's overall health? And a lot of people think that after the tumor's treated, we'll get the scans of the liver, we'll check in with the doctor, and we'll just wait and see what happens. And I have found that increasingly people want to get more engaged with their health. They want to understand their disease, and they want to do everything possible to improve their chances of doing well, even after a diagnosis like ocular melanoma. So what do I tell my patients? Number one, exercise. It is important that right after your surgery, once the patch comes off, once the plaque is out of your eye, it's important that you get back to your regular activity as soon as you can. Even though your vision may be blurred, please push through and do all you can to maintain the level of health and activity that you were doing before this happened. And in people who don't do much exercise, this is a perfect opportunity to start. There have been so many recent studies that show the importance of exercise on mortality, no matter where you're coming from for health. Diet. The field of diet and nutrition continues to evolve. There are numerous specific diets out there, and there are some diets that are recommended for people who may have cancer. I would recommend that however you're choosing to eat food at this point, you seek some professional advice and make changes. I think all of us could do things to make us eat healthier and be healthier. Thirdly, meditation. This is something that I wouldn't normally think I would be talking about, but I find myself increasingly impressed with the data that we are seeing of the benefits of meditation on health. People who regularly meditate have lower levels of cortisol in their blood because you're reducing stress. People who meditate have a higher immune function than people who don't. There is even data that shows that there are epigenetic factors, which means changes happen in a person's DNA that result in better immune function, reducing certain factors that may promote cancer, and an increase in healing. And finally, there is data that shows that meditation increases the length of one's telomeres. And what are telomeres? Telomeres have been associated with longevity. So people who meditate regularly live longer than people who don't. So if you haven't heard of meditation or haven't started meditating, I would recommend that you look into this. There are many resources that can help you adopt this as part of your health routine. I also recommend acupuncture or other holistic approach. When you see your regular doctors, they're going to be focused on your eyeball or your liver or something very specific. However, it is difficult sometimes to have a provider or practitioner help you with a whole body or holistic approach to health. If you don't take care of your whole body, something that is affected by your body, such as your eye or other organ, may not work as well. So I encourage my patients to seek alternative therapies and seek a holistic approach to care. And acupuncture is just one such type of practice. And finally, I recommend that people address possible emotional issues and sources of ongoing stress in their life. There is already an overwhelming body of literature that suggests that disease is contributed to by stress. Whether we decide to agree with that or not, the data is there. And stress is very important in maintaining one's overall health. On the topic of stress and psychological health, I'd like to share some of the research that is ongoing at our center in collaboration with the Department of Health Psychology. We started looking at the results of giving prognostic information to patients because it was controversial to give that potentially bad news. But we found that people want information, and the more you know about your disease, the better you will do. We also looked at quality of life, specifically in the population of people who have melanoma, and we found some interesting results. Most recently, we looked at our first cohort of prospective data, where we looked at people who were diagnosed with melanoma and those who weren't, and found that there are important issues that remain at 3 months after treatment and 1 year. So it's very important that all these issues be addressed, because if you can overcome some of the psychological issues whether it could be from a cancer diagnosis or something perhaps totally unrelated. You can improve your health. So to summarize, I've discussed with you the details of getting a diagnosis, how to think about deciding on the treatment that you will have, what we do here at UCLA if a patient has ocular melanoma, and also I've given you some things to think about on how to improve your health after your treatment. Thank you very much. I now would like to invite any questions, and I understand that we have some questions here. Thank you. So the first question is, I have been diagnosed with ocular melanoma. My doctor has not mentioned the biopsy. What should I do? This does happen, and I would recommend, as I stated before, that it's important to have a discussion with the doctor about performing a biopsy. It could be that this didn't come up in the discussion, but there was a plan to have a biopsy. But if your doctor is not comfortable, then I would ask your doctor, what could you do to get a biopsy? Perhaps there is a colleague or a person who would be comfortable in this situation to offer biopsy for you. And the next question is, my doctor has told me that he doesn't do the silicone oil surgery, although he knew about it. If it is so helpful, why wouldn't he offer it to me? So, silicone oil as part of plaque surgery is something that we have been doing for over a decade here at UCLA. It is slow to be taken up at some of the other centers. There are two main reasons for this, because I have thought about this a lot in encouraging my colleagues to adopt these techniques. Number one is, most centers, most major centers of ocular oncology have very senior colleagues who are not excited about major changes to the therapy. In ocular oncology, treating a tumor with a plaque has been around for 40 years. In other fields of ophthalmology and medicine, many techniques have changed drastically over the years. But I think the second reason is that many ocular oncologists are not retinal surgeons. In order to do a vitrectomy and to be thorough and careful and understand the complexities of the tissues, one must have experience in retinal surgery. The good news is that many of the new upcoming ocular oncologists in North America are vitreoretinal surgery trained, so these techniques would not be a problem. Thank you very much.